it's important to establish a premise before immersing ourselves in all the technical and clinical details of bioceramic sealer. So the importance of obturations procedures is crucial. As thoroughly demonstrated by the scientific literature, chemical disinfection and chemical debridement cannot ensure the complete bacterial removal from the root canal system. So obturation is essential to ensure the long-term success of our procedures. An endodontic therapy without obturation is like calling pizza with pineapple Italian pizza, so it is a shame. But joking aside, obturation is crucial for several reasons, such as, first of all, prevent proliferation of residual bacteria and tomb residual bacteria, prevent penetration of organic fluid, and prevent coronal infiltration. And all of those factors contribute to eliminating the pathology and preventing secondary infection. Over the decades, while my only concern in my health was playing tennis, endodontic companies have introduced several materials that still today perform excellently. And I talking about the combination of gutta percha and Zoe sealers or epoxy and resin-based sealers. However, as usual, they have demonstrated to have some limitation and weaknesses. And here I give you some example. First of all, shrinkage and weak dimensional stability. Second one, the weak adhesion to gutta percha and dentin, cytotoxicity, lack of bioactivity, low antimicrobial activity, and moisture sensibility and hydrophobicity. I'm sorry. I mean, from this point of view, considering their weaknesses, you could think that their performance is deficient on numerous levels, or more informally, they suck. And you're right, but fortunately, the biology and the success percentage of endodontic therapies before the introduction of bioceramic sealer show us how it's more important what we remove from the canal compared to what we insert in it. However, for this reason, for these weaknesses, one of the most important points during the obturation procedures is maintaining the sealer thickness as small as possible and plasticize gutta percha to have a three-dimensional closure of endodontic spaces. As we will discuss later, this paradigm has been completely changed thanks to the introduction of calcium-based silicate calcium-based sealers, also called hydraulic sealers or bioceramics. But before having an in-depth understanding of this point, let me talk about some chemical and physical properties of bioceramics. Please remain focused and don't leave me alone talking with my computer screen. I know it is a little bit boring, but I ask you for a small effort that allow you to understand the incredible power of bioceramics. I promise you will not regret it. Just things you can find and deepen all the information I'm giving to you by scanning the QR code that I usually put in the slide. Fortunately for you, I can speak for only 30 minutes, so to give you a complete vision of this wide topic, I have to make some simplification. However, if you have questions, you can ask me at the end of this webinar or by contacting me through email or Instagram or WhatsApp, whatever you want. So this is the chemical classification of hydraulic or bioceramic sealer. First of all, you have to know that they are composed of a base that could be Portland cement, calcium silicate, aluminum, or strontium. Then additives or modifiers, and then a vehicle that could be aqueous or non-aqueous. That it's really important for the handling. Ignoring the chemical point of view, the vehicle is crucial because it determines how the sealer is presented. I mean, if it's presented in a composition of water and powder or in a premixed form. The pre-mixed sealer is presented suspended in a non-aqueous vehicle and which relies on the diffusion of water from the surrounding environment. And this is crucial for its setting because it needs to attract water from the environment. This process is called hydration. Okay, these latter are supplying as sealing and their use is more user-friendly. On the other hand, the sealer supplied as powder to be mixed with liquid, being their setting procedure during the mixing procedures. So they have a huge drawback, the limited handling and flowability. So my suggestion is to select a pre-mixed sealer. As you can see, calcium silicate-based sealer are different category compared to the Portland cement. This is why they are purified, they are synthetic and cleansed from all injected metals like aluminum and others. So they are better and utilizable as root canal sealer. But now let's talk about the setting procedures, which gives us useful information regarding the power of those sealers. Don't give up. We are almost done with this boring part. And if you stay with me for another few minutes, I have two rewards for you. So the first step is an hydration process that is subdivided into two phases. The second step is a precipitation process. Obviously, you can skip this part, but I would like to focus the attention on this aspect. The process requires water to start, okay? But you ask to me if you have to dry the canal or leave it wet or moist. Also, the scientific literature is asking this question, and to date, the recommendation is to dry the root canal system as you do with traditional sealer. But you say that they need water, and now you are saying that I have to dry the canals. Yes, the sealer takes the water from the environment, from the perpendicular space and the dentinal tubules. So since an extreme presence of water in the canals could compromise the setting procedures, the recommendation is to dry the canal. The product, as you see, the product of the first phase is calcium hydroxide, which is able to increase the pH, creating a basic environment that is a strong antibacterial. The product of the second process is hydroxyapatite, which enhances the bioactivity of the sealer. So this is a brief recap of the excellent properties of bioceramic sealer. First of all, excellent sealing ability with an ability to bond the dentin, antimicrobial activity, dimensional stability and slight expansion, non-shrinkage, microleakage and staining, and long-lasting calcium release essential for bioactivity and hydroxyapatite formation. So thank you for your attention. The boring part is finished, so you deserve two other movie suggestions. The Wolf of Wall Street by Martin Scorsese and The Theory of Everything by James Marsh. I know you're thinking that everybody knows these movies, but don't judge me, I love them, so take them. So now let's talk about another classification, not the chemical one, but the clinical one. This classification is based on the clinical use of bioceramic. We can define three groups according to the therapies performed with the sealer. First of all, intracoronal group, in which we have direct pulp capping and indirect pulp capping, pulpotomy and partial pulpotomy, and revascularization. The second one is the intraradicular group, in which we have apexification and root canal obturation, and then apical plaque. The third group is the extraradicular group, in which we have perforation repair and root end filler. The main aspect to be understood in this classification is that we need different materials in terms of viscosity. In fact, bioceramic sealers are presented in two different forms. Putty bioceramics, also called root repair materials, and fluid bioceramics, also called root canal sealer. The latter must be selected for conventional root canal treatments. For the other treatments, the putty one should be selected. To be clear, the root repair materials have the consistency of, for example, MTA. So the intracoronal therapies, also called vital pulp therapies, since their main goal is to maintain the vitality of the tooth, are possible thanks to an incredible features of the pulp that is the progressive and sectorial progress of the necrosis process. As you see, necrosis is not an all or nothing process, as we believe, but it slightly progresses from the point of contamination to the apical portion of the canal. In this magnified picture, you can see that the upper part is necrotic, the middle one is affected by an irreversible process, and the lower one is still vital. For those reasons, the vital pulp therapies are based on this concept. We have to remove the necrotic and irreversibly affected tissue and put bioceramics on the vital tissue. Fantastic, yes, but is only theoretically, because clinically we are not able to determine the exact point from which we find vital pulp. It is impossible. Nevertheless, we have some clinical tips based on the evolution of sickness symptoms such as bleeding. In my opinion, this is a good point to be investigated in the future, and probably it could be the major innovation in endodontics. Someone has proposed this type of approach, for example, which is based on the combination of non-surgical endodontic and vital pulp therapy for the management of metro-permanent teeth with symptomatic irreversible pulpitis and apical periodontitis. This approach consists of the endodontic treatment of the canal, in which a diagnosis of necrosis or irreversible pulpitis is done, and a vital pulp therapy where the diagnosis is reversible pulpitis. In other words, you make a health endodontic treatment. But pay attention, I'm not saying that it is a recommendation, but it's surely a topic that should be further investigated, and thanks to the bioceramic sealer is a true possibility. And those are the follow-ups. The other groups, and these are two examples of root canal treatment in which I use the bioceramic sealer, and you can see the abrupt curvature managed with it. And then we have the last group in which the bioceramic is used as root repair material for retrograde filling during apicoectomy. So, understood the chemical and clinical classification, now we can talk about obturation techniques. But first of all, I would like to remark again that with this material, we have to shift our concept of obturation. As I was saying to you before, due to the weaknesses of traditional sealer, we should limit as much as possible the thickness of the sealer, and the curve of our obturation procedures would thermoplasticize good aperture. Now we are in front of a paradigm shift thanks to the excellent properties that I have shown you before. So the current material is no more the gutta percha, but the bioceramics. And the gutta percha should be considered only as a carrier to bring the sealer to the apex to expand it three-dimensionally, enhancing its hydraulic pressure. Now, the big question, can I eat the bioceramics? Wait one step at a time. First of all, we have to specify that initially the bioceramic sealer have been recommended to be used with cold techniques. And this remains their main indication. However, the research has discovered some important information on this topic. So let's dive in it. As I was saying, we can divide the obturation techniques in two different groups: the cold hydraulic condensation and the heat-based technique. First of all, we have a pumping technique in the first group and the injection technique. In the second group, we have the mild warm technique and the thermomechanical condensation. So we have four types of obturation techniques. But how many times have you heard, do not heat calcium silicate-based sealer? It is not necessary, you ruin the bioceramic. Actually, those sentences are not completely wrong, but let's make it clear. First of all, we have to underline that by heating the bioceramic sealer, we can have those problems. First, that is not a problem. The tricalcium and decalcium bands remain unaltered, so it's okay. Second one, the degradation and polyethylene glycol degradation and a consequent drastic reduction of flowability, which is probably one of the most important physical properties of the sealer. Obviously, because without it, they cannot three-dimensional fill the root canal system. The third problem is that the setting time reduction. However, those considerations were valid only for some bioceramics, not for all. First of all, we have to define the threshold temperature above which we can observe those drastic phenomena. The scientific literature has deeply investigated this topic, and I would like to summarize for you the most important concept. First of all, you cannot eat all bioceramic sealers. In the literature, there is data only on those products, okay? And we surely know that they can be eaten. However, if you want to eat other sealer, please test them before or wait for some scientific research. So as you can see, those are the bioceramics that you can surely eat at a certain temperature, but you have to do not exceed 100 degrees of temperature. And then you have to remain slightly far from the apex with your heat carrier. Then define the actual heat capacity of your heat carrier. So this is why the actual temperature of your plugger usually is not the same evidenced on the display of your device. So now that we have clarified also this point, we can talk about obturation technique one by one. The first one is the cold technique, the first pumping technique. The clinical steps are those: master cone fitting, you have to reach the working length and have an apical tuck back, as you see. Place the sealer in the root with files, lentulo, or mostly with gutta percha, and repeat this phase until the gutta percha point or file is entirely covered by the sealer when removed. Then cover, as you see, the apical part of the gutta percha cone with sealer and gently insert it to the working length or 0.5 millimeters short, and gently perform 3 pumping motion up and down movement to increase the hydraulic pressure, and then cut the coronal part of the master cone. Okay? If you want, you can take a picture. Then we have the second one, that is the injection technique. And the clinical steps are quite similar. They differ only for the way to place the sealer in the canal. So, first of all, master cone fitting, working length and apical tuck back, like this. Second one, inject the sealer in the root with a syringe inserted up to the middle third of the root, like this. Then you have to cover the apical part of the gutta percha cone with sealer and gently insert it to the working length or 0.5 millimeters short, like this. After that, you can do gently 3 pumping motion up and down movement to increase another time the hydraulic pressure, and then cut the coronal part. And those are the clinical steps. On the other hand, we have the hot technique. So the first one is the mild warm technique. So first, as always, master cone fitting at the working length and perform and verify that there is an apical tuck back. I'm sorry. The second step is place the sealer in the root with file. Obviously, you have to select the plugger, and it should arrive at 5 or 6 millimeters from the orifice, not more. Insert the gutta percha point and then cover the apical part of the gutta percha cone with sealer and gently insert it to the working length or 0.5 millimeters short, like this. After that, you have to gently insert the heated plugger with a temperature selected not more than 100 degrees. And first of all, you can cut the orifice, the coronal, the most coronal part of the gutta percha point to see the orifice and where it's located. Then you have to gently insert the heat plugger until the reference point that you have taken before, as you see in the video. After that, see what in the lower part of the video, the hydraulic pressure that comes in the MB2. After that, maintain apical pressure for 10 seconds. Activate then the heat plugger for 1 second and withdraw heat. Then apically compare gutta percha with manual plugger, called manual plugger, and perform the backfilling procedures. And this is the clinical steps. The second technique is not very well spread, but I had my group research. I've published an article on it, and it is based on the thermomechanical compaction of gutta percha with the gutta condenser. The gutta condenser is a stainless steel instrument with inverted flutes, which should be rotated at 8 or 12,000 RPM in a clockwise direction. The clinical steps are master cone fitting and selection, as always, sealer and master cone placements, gutta condenser insertion and selection, and then insertion at 8 or 12,000 RPM until it reaches 3 or 4 millimeters from the working lamp, or more coronally if you have a severe curvature, for example. Don't worry, because the hydraulic pressure helps you in reaching the stringency of the root canal system. Then you have to rotate the gutta condenser until the gutta percha is softened and apically pushed, and it's over. With this technique, you should be sure that to have performed a great gauging and that you have a good apical tapback, because the apical force is very high. The great characteristics of this technique is that you are sure to not exceed 85 degrees of temperature, so your physical and chemical characteristics of bioceramics are preserved. Everything sounds good and perfect up to here. However, someone could raise some limitation of bioceramic sealer. The first point is the oval canals. The most frequent criticism is the obturation of oval canals, in which the use of bioceramic with hydraulic techniques could cause voids. Actually, it is true that in case of oval canal, the hydraulic pressure techniques are not strong enough to push the sealer laterally, specifically in the major axis direction. But one solution to this problem is the use of heat-based techniques. As you can see in this micro-CT study, with thermoplastic techniques, we can significantly reduce the voids. And this is an example of this use, okay? An oval canal and the obturation 3D. So the heat-based techniques are recommended to increase the hydraulic pressure in oval canals. The second criticism usually raised is the possibility or impossibility, of retreating root canals obturated with bioceramics. This is a very hot topic in endodontics, because this limitation, if true, could be detrimental for bioceramics. As always, my philosophy is to distrust the common belief and find my answer in the scientific literature. Regarding this, the increased number of published articles in the last few years is evident. I have selected for you one of the most representative articles on this topic that gives us interesting clinical suggestions. The author investigated the possibility of regaining the working land and patency during retreatments. They also evaluated the time required for the procedures. They defined 4 groups, as you see, according to the selected sealer, H+ or bioceramic, and according to the working land. Group 1, bioceramic and single cone placed to the working land. Group 2, bioceramics and single cone placed 2 millimeters from the full working land. Group 3 H plus at a working length, and group 4 H plus far 2 millimeters from the full working length. The results are clear. Working length and patency have been regained in all cases when a traditional sealer is used. But much more interesting are the results regarding the bioceramic sealer. The length to which the good aperture point is placed is crucial, because placing it 2 millimeters shorter from the working length is detrimental, because it jeopardizes the ability to regain the working length and the patency in a significant way. On the other hand, if the good aperture point is inserted at a full working length, there are no problem in the retreatment, because the endodontic instruments are able to follow its softness up to the apex and regain the full working length. So we are coming to the end of the presentation, so it's time to make our final price and suggestion on the use of bioceramics. In case of primary root canal treatments, we must, first of all, place the GP point to the full working length. If you are not sure to have reached the full working length, don't use bioceramic sealer because of the problem in the retreatment. Use bioceramics as sealer, not as filler, so we are able to retreat it. So place the good aperture at the full working length. In the case of all canals or irregular anatomies, select it-based techniques, not exceeding 100 degrees of temperature. In case of root canal retreatments, we must use ultrasonic tips and rotary reciprocating instruments, obviously. Chloroform could help us in disgregating the bioceramics. Then activation of irrigants, of course, and use stiffer stainless steel manual fine, for example, C-Pilot, C+, or MNC. Now you might be wondering, okay, it's all clear, I hope, but how could I select the right bioceramic sealer? And you're right, because the market is now full of bioceramics and the offer is very big. But as we discussed, not all bioceramics are at the same level. Here are some characteristics you should check before buying the sealer. And there are mainly 4 parameters that you have to evaluate. First of all, the percentage of silicate calcium in the sealer that the manufacturer should indicate in the brochure. Beware of who hides it. The second one is the chemophysical property like flowability that, as I said before, is very crucial for hydraulic condensation. The third point is the handling. And the fourth point is the price, because this is one of the limitations, because they are more expensive than the traditional sealer. So those are the threshold that you should have as a reference. First of all, the percentage should be greater than 30%. According to the chemophysical properties, the flowability should be greater than 25 millimeters at each temperature, because as we said before, the hot could reduce the flowability. So if we increase the heat inside the canal, the flowability should remain greater than 20 millimeters. The 20 millimeter is taken from the ISO standardization. The third point, the handling. As I said before, the premixed sealer should be selected. And obviously the price, you have to select the cost effectiveness one. Now, obviously I show you my choice and you are never going to believe this, but the direct endo bioceramic sealer is amazing. But joking aside, check why this is my choice. The direct endo bioceramic has a 40% of calcium silicate in the sealer, so it is great. The second point is that it guarantees a flowability range from 25 millimeters to 21 millimeters in case you eat it, okay? The third point is that it is a premixed sealer, and regarding the price, it's absolutely comparable to the traditional sealer because it costs 69 euros. So thank you for your attention. I have given you all the necessary information to start using bioceramic sealer. Obviously, it's a little bit different from the traditional one, so it requires some practice. Do not be afraid. Get in the game, because bioceramics are the future and you cannot stay behind.